request the panelists to give their comments. Dr. Ross Scott can give his thoughts about any of the topics. Dr. Ross Scott, please.
Yes, thank you very much. And again, also thank you to Dr. Muralidhar for an excellent meeting. And Dr. Jasapara did a very good job of giving a review and a summary of HTE, which I've been involved with from the beginning. So I had a question for Dr. Jasapara. I noticed that in your literature summary, you indicated that there was quite a high rate of right ventricular dysfunction. And I was wondering if, from your perspective, does that match your clinical experience in your institution or not?
Yeah. So thank you, Dr. Ross, for appreciating the lecture. As you said that we do a lot of bad valvular cases as well as ECMOs and LVADs. So we have seen a very high incidence of post-op RV dysfunction. Initially, with the absence of TE, it was very difficult to appreciate whether the cause of hemodynamic instability was, we could not come to the diagnosis. We just started with inotrope. With the clear and direct imaging of the right ventricle, of the myocardium, we have seen a high incidence of RV failure in the post-operative period, especially with these cardiac surgeries. That is true.
Yeah, that's very interesting. We see the same thing in the States. And I was wondering if you had any just pearls of wisdom for the group in terms of how you then go about and manage those patients. Has the ability to detect RV dysfunction post-op in these patients led to any changes in your management of those patients?
So our aim at all the times should be not to progress till the stage of overt RV failure and then start the treatment. Mm-hmm. Once the RV failure sets in, it is very difficult to recover the RV. Yes. So it's just like we use a lot of diuretics in the preoperative period. Then for contractility, we use a lot of milrinone along with an adrenaline combination. That is a very good combination we have noticed, and a lot of use of nitric oxide. At around for all our transplant and VAD patients, we start with around 20 to 30 parts per million, and then titrate according to the effect. And lastly, we have till now not used RVAD any time, but lost a few patients to RV failure also. But yeah, so it's just timely institution of medications will prevent any overt RV failure. Once you have direct, you just anticipate RV dysfunction and treat it. That's what I would like to say.
Very good. So the take-home point for the audience from you might be then the early detection and proactive management of RV dysfunction to avoid RV failure. Is that fair?
Yes, I would agree, sir.
Excellent. Would it be okay if I shared a brief video to add something to your future slide?
Yes, sir. That would be very much welcome, sir.
Something completely new for this audience related to your talk and just essentially adding to the, to the future slide, if you will. So if it's okay, I'm going to just briefly share that. Can you see this?
Yes, sir.
Yes, we can see.
Yeah. So in addition to the views that you mentioned and the qualitative assessment, we asked ourselves the question, if the probe is smaller and it can be left in for a longer period of time, where would that provide a significant advantage? And so one area that you mentioned certainly is that in the cardiac patients is the right ventricle. But we also found in the non-cardiac patients that volume management was particularly important. And so this is an example of a patient in septic shock. Whereas, the problem is more or less multidimensional. So volume, contractility, and their vascular tone as well. So I'm just showing you a preview. It's not yet, this software is not yet FDA cleared. So you can see it says investigational use only, but I think that this audience could appreciate the future direction of, I think, many of these ultrasound tools is to add machine learning or artificial intelligence. And essentially it's just automated border detection and showing the size of the left ventricle through time, and then automatically calculating hemodynamic parameters for the user. So this is getting closer then to really a bedside monitoring tool. So just something to add to your future perspective on where this is going. So I'll stop that now. Okay, very good.
Thank you, Dr. Scott, for that excellent comments.
Thank you.
Dr. Jagdish, do you have any comments?
Yeah. Thank you, Dr. Prabhati. Is Dr. Rajesh Shetty there?
He must be there.
Yes, I'm here.
Okay. Thank you, Rajesh, for that very educative presentation of a relatively uncommon modality in clinical settings. But my question is, what are the changes of these delicate signs when the patient is on IPPV, that's when the patient is on a ventilator? These signs, do they change?
I think this question is not for Rajesh Shetty. I think my presentation is next.
No, for the lung ultrasound.
Okay. I didn't. I thought it was starting. My presentation was starting now. Has it finished already?
Yes, yes.
Yeah, you were
Lung ultrasound.
you were first in the session.
Oh, is it? Sorry. I thought it was at 10:30. Yeah. Can you repeat the question again, please?
What are the changes that you find of these delicate signs that you have mentioned, the A lines
Yes.
and B lines and comet tail artifacts, when the patient is on ventilator?
Yes. What the A lines, B lines, and all that we haven't found much difference. Probably the atelectatic changes might differ depending on whether you are doing any recruitment maneuver, especially if PEEP is high. You might see that the atelectatic changes will reduce. But A lines, B lines, most likely it may not change much over a short period of time.
Okay.
But the diaphragmatic thickness, we have seen a difference depending on if the patient is on ventilator or not, and how much support they are receiving. For example, the previous speaker spoke about the thickening fraction. There are some of the papers which have shown that if it is between 15 to 35%, probably the patient is getting adequate ventilatory support. If the patient's thickening fraction is less than 15%, it means the patient is getting too much ventilatory support, and that is probably the reason for diaphragmatic dysfunction, because diaphragm has got no chance to work. Whereas if it is more than 35%, it may mean that the patient is getting too less support from the ventilator, and that the diaphragm is trying to overwork and compensate for it. And those patients probably are not suitable for trial of extubation or weaning from ventilation. So diaphragmatic thickness probably has a dynamic relationship with ventilation. Others are probably one-off change, and after that probably they will remain constant and will only vary depending on the pathology of the patient. For example, if they have worsening pulmonary edema, your B lines will increase. Whereas if you are given a diuretic or a patient is on dialysis and you're removing fluid, the B lines will reduce.
And there's a question for you in chat box. How many B lines do you require to consider as pulmonary edema? By Dr. Sanjeevani Namdar. She's asked the question.
There was one slide about that as well. Depends on which probe you're going to use. If you're going to use a linear probe, up to 4 to 6 B lines are considered as normal. And more than 6 B lines in one frame, you would think that there are extensive B lines. And also it depends on which part of the lung you're examining. For example, if it is base of the lung, you will have some B lines normally, even in normal patients. Whereas on the apical portion, probably it's going to be more abnormal. And for pulmonary edema, not only you would say that, okay, this patient probably has a pulmonary edema, depending on the clinical context, whether it is worsening or getting better as well.
Correct.
And
correct.
you will have a response.
The prognosis.
Yes, yeah.
Yeah. Okay, thanks, Rajesh. Nice.
Thank you.
Dr. Pradeep, can I have a question to you?
Of course, sir. Yes.
Yeah.
My pleasure.
Thanks. Very nice presentation. That VIDD,
Yes.
is it related to the pattern of ventilation or the duration of ventilation? Or can you just tell us in your experience VIDD?
Sure, sir. It's. I think what you've asked is an extremely important question. If you personally ask me, I work in an ECMO intensive care unit, and also look after patients in the cardiac ICU. If you ask me, ventilator-induced lung injuries is an underdiagnosed phenomenon.
Correct.
And if we can identify patients early using techniques such as ultrasound, that is fairly non-invasive and can be easily performed with a short course of training, and has less intra and inter-observer variability, we can identify these patients and target certain strategies to liberate them from mechanical ventilation. Now, where we find difficulty is in patients, especially in the first two surges of COVID-19, where the mean duration of stay of patients on ECMO was at least 30 days. And in the first stage, we saw patients who got liberated from ECMO being on ECMO for more than 60 days. And on the second surge, if you wouldn't believe me, patients who have been on ECMO for more than 120 to 140 days and liberated from mechanical from ECMO and are rehabilitating currently. Now, I don't know, and the answer is, I hope we have the answer from studies that how ultrasound can be utilized in these patients who where we rest the lungs and initiate extracorporeal support. But I still believe that monitoring the thickening fraction is useful, even if the patient's spontaneous effort is very meager. So the answer to your question, sir, is both. It depends on the duration as well as the way we ventilate them. As Rajesh pointed out, titrating the load to the patient based on the thickening fraction would be ideal. Thank you, sir.
Thank you very much, Dr. Prabhati.
Yeah.
Can continue. Yeah.
Actually, there is a question. What are the indications for assessing the diaphragmatic movement on ultrasound?
Madam, can I clarify that the indications?
What are the indications? Yes.
Yes. Okay. Well, for the intensive care physician, if you personally, my perspective is that anyone who comes to the ICU gets a whole body focus on admission, which includes the ultrasound of the diaphragm. And if we figure out that a patient is difficult to wean, and we perform an 8 to 12 zone ultrasound, lung ultrasound, together with two-dimensional and M-mode assessment of the diaphragm on a regular basis, and monitor their response to the ventilator settings. So if you ask me personally, it is fairly essential in most patients. In the outpatient setting, if having worked with a colleague of mine as a thoracic physician who teaches on the same course as I do, and he uses ultrasound in the outpatient setting because unilateral diaphragm dysfunction is difficult to diagnose clinically, because they don't patients with symptoms as much as patients with bilateral dysfunction. Using ultrasound in those patients is quite useful, and by monitoring the excursion during sniffing, during deep inspiration, easily identifies diaphragm paralysis. And the other group of patients I'd like to mention is those patients who've undergone thoracic surgery or even cardiac surgery, where you suspect that the phrenic nerve may have been injured, and monitoring diaphragm on admission through their course to liberation from a mechanical ventilation might be a useful tool if we think that the diaphragm paralysis is the cause. I hope that answers your question, madam.
Thank you. Thank you very much. Dr. Rajesh, do you want to
Yes,
add
madam.
anything?
Yes,
I think the question was about indications for ultrasound of the diaphragm. As Dr. Pradeep said, I would do it on a regular basis, at the time of admission and on a daily basis as well, because as we said, the load can be titrated as per the diaphragm function. So, when patient is on ventilator, you want to know whether whatever support you are giving is adequate or not. And also when at the time of extubation, you want to know whether they are ready for extubation. Our practice in our unit is to do ultrasound every day. And as part of the ultrasound lung, I would do ultrasound of the diaphragm as well. Any patient on the ventilator, I would do the ultrasound of the diaphragm.
Thank you. Thank you for that input.
Thank you.
Dr. Rajesh?
Thank you.
yes.
Rajesh Toshani? Any comments?
Yes, thank you.
There's a question to Dr. Amish. That is a very nice presentation. He is using HTE. So there's only limitation to make a views with the use of HTE. So how can you check a volume status? Because mostly we are checking a volume status by inferior vena cava, looking the measurement of diameter of IVC. So is it possible to check the SVC diameter and we can tell the volume status of the patient?
Is it a question to me? Oh, sorry. Okay,
Yes,
please go ahead.
yes, Dr. Amish.
Yeah, so it's a very nice question. So conventionally for transthoracic, we are using the IVC diameter and in spontaneously breathing patients to check the volume status. But in ventilated patients, at times IVC may not be easily accessible because of the mechanical ventilation. In such cases, SVC is easily visible with the use of TE, whether conventional or whether HTE. And these respirations, the variation with this respiration, it's easy to detect the fluid responsiveness. Now, there are many studies, especially if you have read by one study by Dr. Philippe Vignon, which is a French study, which has shown that a respiratory variation in SVC of more than 36% has detected and has shown that these patients are fluid responsive. So a serial measurement of these respiratory variations can give an idea about how these patients are responding to the fluid challenges.
Okay, thank you. Dr. Niranjan, I think we are left with only 1 minute.
There may be a question in the chat box. Just check, Dr. Prabhavati.
Oh, I'm not getting any questions.
Okay.
Dr.
I'll show-
Niranjan, Vate, any
Please
comments?
unmute yourself. Please unmute yourself.
Yeah, you can comment and then we may have to close.
Yeah, am I audible?
Yes, yes.
Yeah, so I have a question for Dr. Satish Goel. Sir, is there a difference in could you comment on the point of insertion? How do you select the point of insertion on the septum? Is there a difference between when you do a mitral clip or a transcatheter mitral valve replacement?
Yes, for the mitral clip, it is posterior and superior, and the recommended distance is about 4 centimeters for a degenerative mitral valve. Especially when you have a prolapse or a flail, you'll have to go a little higher, maybe even 4.5 centimeters above the annular plane. But if it is a functional MR, then in MitraClip again, if it is a functional MR, you can go a little lower down because the coaptation point descends down, it's more epically displaced. So even up to around 3.5 centimeters, or sometimes in the literature, they say even around 3 centimeters. So that is the difference between the two types of the etiology when it comes to MitraClip. For the other one, I think the question is about a valve-in-valve, which you are probably mentioning. So for that, it needs to be a little lower down. It again is posterior, but probably somewhere between 3 and 4 centimeters. And many of the interventions feel like it's something like a PTMC puncture where you go a little lower down.
So we would use the bicable view to understand whether we are doing superior or inferior.
Absolutely.
And the aortic short axis view to check whether we are anterior and.
Yes, a 3D probe with both the simultaneous posterior, that is the short axis, and then you have the bicable, which gives you the superior inferior with the X plane or the biplane. I think that is an absolute must, and that makes your job much more easier. And the tenting is very important, so you can really guide them at that point.
I think we need to close the session now.
Yes.
I know there will be a lot of questions. It's very, very interesting topics. This is a wonderful session. Even I learned a lot from all of you. I thank all the panelists and speakers for sharing their knowledge. I immensely thank Dr. Muralidhar for arranging this fantastic conference and making me to participate in this. Thanks to one and all. Thank you very much.
Thank you.
Thank you very much. Thank you.
Thank you very much.